everybody AIOS for organizing this wonderful session and for inviting me to participate.
So Gaurav, we need to acknowledge thanks to you for helping to coordinate with the session,
Namrata, it's
the
always a
refractive as well as the cataract both. Thank you.
you're welcome. It's really nice to see it coming out so well. So, I think I'm first of all apologies that I've joined a little late because I miscalculated the time and there were big traffic jams today, and I could only join later. So I missed a couple of the initial talks, and I think Dr. Praveen Krishna has already spoken in the beginning of the session on PRK.
No,
So
no, no, Gaurav, he did not because he
okay,
got
he
stuck
was
in an emergency. So
all right.
PRK
So
is all
I'll try to
yours.
cover up PRK as little beyond what I would have done
Yeah.
otherwise. So I actually wanted to speak after Praveen.
Gaurav, 1 second. I thought traffic jams was an excuse in Delhi.
Sir, 2 kilometers in 40 minutes.
And I think you could have joined anywhere, right?
I could have walked it, sir, actually.
Okay.
Actually. Or maybe cycled it. So, today I was going to speak on painless PRK. Is it possible or is it really possible? And, while we've spoken so much on SMILE, and I, of course, have SMILE as one of my first preferences for refractive surgery today, but there are always going to be instances where you may have to fall back. So a good refractive surgeon should have all techniques in his armamentarium. And we've seen refractive surgery evolve. Most of the speakers here are all those who are so experienced. They've gone through almost all of these processes, starting first with maybe PRK in the 90s, and then going on to LASIK because of the inherent problems with PRK, which we faced right in the beginning. With regressions and so many other things. I'll come to that, and then going on probably to LASEK and epi-LASEK, and then advanced surface ablation, where we learned how to do PRK better. Then evolving on to femto-LASIK, which ruled for a long time, and then finishing off with SMILE, and then today we saw SMILE Extra, which seems to be taking it to the next level. But frankly, the evolution of PRK has not stopped with advanced surface ablation. We are continuing to evolve, and it still holds a good place. And there are surgeons who do purely surface ablations as well today. So the advantages of PRK, of course, no flap as in SMILE, better corneal stability, probably the lowest incidence of induced ectasia, no flap related complications, faster recovery of the corneal nerves, which minimizes the amount of dryness. I still feel that SMILE is more friendly to the ocular surface than even PRK, but still PRK does extremely well. Extra margin of safety in patients when you're dealing with healthy thin corneas, or maybe with steep and flat corneas where you would not want to make a microkeratome flap at least, for those of us who do. And it's also the preferred procedure for professional athletes, some of the people who join forces, and where there is risk of physical contact. And as I just mentioned, ectasia is extremely rare with surface treatment. So the added, safety for the surgeon and the patient alike. But there are limitations, and while we've kind of conquered many of the limitations, there is, of course, the mild to severe eye discomfort for the first day at least, and maybe for the first couple of days following the procedure. And there is, of course, the longer period of visual recovery. So patients can take a good week or 10 days for good visual recovery where they're comfortable, while most patients do reach 6/9 or 6/12 on day one, and sometimes even 6/6, but it can take almost a week as the epithelium heals. And haze used to be the thing which haze and regression were two things which, when we started doing PRKs, we were dealing with haze, and people were doing big treatments, deep ablations, small optical zones with the older type of lasers, the broad beam lasers, where the incidence of haze was much higher, and then the regressions were seen. So that's why we went on to do LASIK. So haze has been now very rarely seen with appropriate use of mitomycin. And the regression, I think, is with the modern lasers. We don't see, in fact, we don't even change the nomograms anymore for PRK, which we used to do 15 years back. So current status of PRK, I think haze is extremely rare. The refractive stability is excellent. We've understood how to do that. So what holds us back from doing more surface treatments? I think that's the big question. When everything seems to be going so well, what is it that still stops us from doing this? So I think pain remained one of the things which was the discomfort. Many surgeons I speak to, when they consult me for some of their cases where they would like to take a decision on what they would like to do, and I tell them go to surface, they say sorry, we don't do surface at all. And I am always forced to ask, and the usual thing is that they are uncomfortable because the patient will feel uncomfortable with the pain. So I think there have been lots of things that have been done over the years for pain control. People have tried all kinds of things. The changes, the important changes were use of the BCL, use of chilled BSS, and the comfort drops. Some people used to use, but I don't like to use them because they were using combinations of topical anesthetics, which can cause complications. People have tried oral bolus steroid, oral analgesics, and so many other things. So I think pharmacological and non-pharmacological treatments have all been tried, and yes, they have been successful to a large extent. But pain continued to remain a bit of a problem for these patients. And this, of course, you can see the cold patches and so many other things. So many studies were done, and we've gone through all that. Now the benchmark, I think Rohit is also here, and I picked up using this almost 2 years back. What I'm going to talk about today from Rohit himself and from Narayan Netralaya work is they wanted to describe the study of AccuVale 0.45% ketorolac solution, which was in the UNIMS, and for pain modulation in patients undergoing trans-PRK. And it showed excellent results. I started doing this more than 2.5 years back, and there has been no looking back whatsoever. I think using bandage contact lens soaked in AccuVale to begin with, and now since AccuVale is no longer available, we are using a substitute which I'll just be telling you about. It works as a good reservoir for the medications such as the NSAIDs for sustained release, and it helps dramatically helps patient with better comfort, much cleaner looking eyes next day. And of course the pain element has been dramatically reduced with this thing. So instead of AccuVale, now we are using AccuSaid, which is recently available from one of the companies. I have no financial interest, but we did a study for them for about 30-40 eyes to begin with, and we found it to be equally effective as we were doing with AccuVale. It's from NTOD, and comes in UNIMS, and this is how we were using this. So it comes, you can with the UNIM, and we just, so I think Rohit at Narayan Netralaya they do it differently. They soak it for 30 minutes. We do it at the start of the procedure. We are soaking it for just about 5 minutes. We open the blister pack and we kind of drain out a little bit of that fluid. The fluid is drained out, the contact lens remains there. And after that, you can just kind of put the, from the UNIMS, you can put the drops right there into the thing. Now, you have to decide what protocol you want to follow. The protocol followed at Narayan Netralaya has been published, and I think that's something which is published, so you can maybe go with that. And we have been then at the end of the procedure. So this usually is about a 5-minute thing soak time for us, and it works extremely well for us even with the 5 minutes. And then of course you can just place the BCL. So anyway, going on. The procedure itself, I think, is, I won't show you the whole video, but maybe at the end, this is a trans-PRK procedure. We found trans-PRK to be extremely good. We are using the Wavelight platform with the Streamlight, and we now have about 100 plus eyes on the trans-PRK. Seems to work really well. Also, impacts the patient for, this is how we are applying the mitomycin, and this can be then irrigated at the end of the procedure. So trans-PRK has been another addition to PRK where patient comfort has been extremely good, and the healing times are much faster. The eyes are more predictable. Of course, you just need to make sure that you have the right epithelium thickness from an OCT-based epithelium thickness mapping device. And that helps you customize your patients to have the exact epithelium. And believe me, while we might follow the 10% rule where a 500 microns cornea will usually have a 50 microns, but there are big surprises. There are thinner corneas with 55 microns epithelium, and there are thick corneas with just about 48 or 49 micron epithelium. So going on, I just wanted to share this quick short video. This was a patient post-op. Day 1 was operated in the evening at 8 p.m. Next morning, most patients with PRK would not open their eyes like this. They would have edematous lids to begin with, and this is almost a 2-year-old surgery. And eyes look absolutely clean and white. You will not find usually any kind of edema or congestion which you would normally find with alcohol-assisted or other procedures. And patients are even reading 6.6 on day 1 post-op, and this patient was able to read. So just for the benefit of showing that patients do extremely well. So going on, cautions. Yes, I think that's very important. Potential ocular adverse effects from topical NSAIDs, we've all learned over the years, include transient burning, stinging, and conjunctival hyperemia. And of course, the possibility of getting punctate keratitis, corneal infiltrates with PRK are possible. But if you follow all precautions, they're extremely rare. Persistent epithelial defects and corneal melts. Now, I have to list these because they are important, that you should know that these can happen. But if we follow all the proper guidelines of PRK, you almost don't see them very often. They're extremely rare, just like ectasia is rare with LASIK and SMILE today. But going on, I think we should do for doing a good trans PRK, at least you need epithelial thickness mapping. Otherwise, of course, PRK with the brush or Amol's brush is equally good. And this is how we customize our trans PRK patients. And this is a post-op patient with a BCL on top. They look pretty good. This is part, healing on day 2 or day 3, where you have thickness of just about 30 microns on the epithelium. And then usually we follow up our patients with epithelium mapping post-op for almost up to 2 to 3 months. And it's really a miracle, quite eye opener to see how the epithelium really heals post-op. So possible implications of what I was talking about just now with the painless PRK. I think for us, for most people, PRK is only 5 to 10% of refractive procedures. And as I said, many surgeons don't perform PRK at all. If pain was sorted out, there may be a major shift towards the surface, given that the risks of flap complications and ectasia, and even the financial implications, because all you need is an excimer, which most LASIK centers do have. So, investing into a big expensive Visumax or a femtoLASIK would be, or even a microkeratome may not be there if PRK was possible in majority of cases. And at LV Prasad, they've been treating treatments as much as -10. I think Praveen himself has undergone a treatment of -8 or something, and they are finding it to be extremely good. So the phase of refractive surgery may completely change in the near future with so many things happening with SMILE, with the surface and everything. So I think I'll stop sharing. I hope I was able to make sense.